Every great journey begins with a single step. And at Jesse K. Hospital College of Health Sciences, that step is met with warmth, guidance, and possibility. Here, learning goes beyond the books. It is where future healthcare heroes are nurtured by passionate instructors who believe in their potential. From theory to practice, our healthcare assistant students gain real-world skills in real healthcare settings, preparing them to serve, support, and make a difference from day one. Because at Jesse K. Hospital College of Health Sciences, we don't just teach healthcare, we empower excellence. Admissions are now open for our January and February intakes. Step into your future today. Find us at Blessed House, 5th floor, opposite Garden City Mall. Jesse K. Hospital College of Health Sciences, empowering excellent healthcare.
At JCK Hospital, we understand that a child's smile is priceless. That's why our dental services are tailored with care and compassion to ensure your little ones have the best experience possible. From gentle checkups to specialized treatments, our pediatric dental experts create a safe and friendly environment, making every visit fun and stress-free. Because we believe healthy habits start young. And for the grown-ups, we've got you covered too, with top-notch dental care for the whole family. Visit JCK Hospital today, located in Roysambu, opposite Park University on Lumumba Drive, and experience dental care that's gentle, professional, and family-friendly. JCK Hospital, you first.
A very good morning to you, our viewer. Welcome to the healthyyou program, powered by Faith Today TV, and we are proudly sponsored by JCK Hospital. And today, it's yet another day we have brought you an amazing program. It's always a great time to come and inform you on matters leading healthy lives. So if you are healthy, both in the mind, in the body, and in the soul, it is easier to lead prosperous lives. And today, we are dealing with mothers. If there is something that is so special to my heart, is mothers. They are very special to my heart. And today we are going to be decoding. There are very many people who, once your woman is expecting, your lady is expecting, you have a lot of anxieties, you have a lot of expectations, you have a lot of misconceptions and myths. We are going to be handling that today, from admission to recovery. What is that journey of going through CS look like? Most of the times when you hear a doctor is telling you now, your lady has to deliver, yes, but the process is as follows. So we're going to be decoding that, debunking the myths, debunking the misconceptions, and clearing the airways so that you get to understand how does it look like. So we're going to be killing that anxiety. We're going to be clarifying all the things that you do not know clearly in matters cesarean section. And today I'm joined with a very big team. It's the first time, and I'm so excited about this because it's going to be a deep dive. We're going to be diving together. Please find yourself a swimming pool. It's cold. Be careful not to jump in. So I'm joined with Dr. Shem, Mudavadi, Vincent, and Dr. Makori. In a minute, they're going to be introducing themselves. We'll begin with Vincent.
Hello, how are you? My name is Vincent Mudavadi. I'm a theatre nurse. My role is to help mothers transit well during theatre process.
Wow, karibu sana daktari.
Thank you.
Yes, good morning, viewers. Thank you so much, Stanley, for having me again on this show. My name is Dr. Makori from JCK Hospital. I am a medical officer, and my role generally for today will be helping mothers deliver safely through cesarean section.
Wow.
Yeah.
Thank you very much, Mr. Stanley. My name is Shem, Kyalo, the assistant. Okay. My role is to give safe anesthesia to patients that are coming to theater, specifically in this time for mothers. Thank you.
Wow, profound. Karibu sana. So today we're having an amazing team and we're going to be taking you through the journey of the cesarean section. You're wondering, you've been told this whatever is going to happen. We're going to take you into the behind the scenes of what really happens. Is it okay if we get into it?
Yes,
Perfect.
yes, sure.
So, Daktari,
Yes.
many mothers fear cesarean delivery because they don't fully understand it. Maybe help us understand when that announcement happens.
Okay.
What do you mean?
So generally, motherhood is a beautiful journey, and it's understandably so that when your doctor breaks the news to you that you'll have to undergo a cesarean section, you might have those jitters, but that does not mean that it's not safe. Although we prefer and it's recommended that the best mode of delivery is the normal delivery. It's not that normal as there is no abnormal delivery.
Yeah.
Both are normal, but vaginal delivery is the safest mode of delivery. So going to that, there are two types of cesarean sections. There is the emergency cesarean section. That is when it is noted that during the progress of labor, something might not, the outcome might not be favorable both for the mother and for the baby. Because at the end of the day, when you come to hospital, all you want is, we want a healthy baby and a healthy mother. So go home, both of you healthy, and the partner who supported you through that, all of you go home as healthy. So when this normal delivery per se in quotes is not favorable, that's when we turn to a cesarean section. To define a cesarean section is whereby we make an incision in the lower abdomen. Most of the time, sometimes it might not be in the lower abdomen. We might go through another incision, but most of the time it's an incision made through the lower abdomen. We go through the layers of the abdomen and extract the baby and repair everything up.
Wow.
Yeah.
Profound.
Yes.
So it is not a medical necessity sometimes.
It's not a medical necessity and it's discouraged.
It is discouraged. It's
But
not even compulsory.
It's not compulsory. Yes.
Oh, profound.
Yeah.
So that has cleared a lot of airwaves because people feel every time you mention a cesarean section,
Yes.
oh my God,
Yeah.
it's done.
Yeah.
It's done. But thank you so much for clarifying that.
Yeah.
Maybe you can help us. Once a mother arrives, explain why mothers never feel they have failed because of having a CS. Why should they never feel they have failed? Because for many mothers, it's their wish.
Yeah.
They undergo vaginal delivery,
Yeah.
which we call quote unquote
Yeah.
normal delivery. But now they're announced, it's announced to them that they have to go through the CS delivery.
Yeah.
So why is it that they should not feel as if they've given it's a misfit for them?
Yeah. I think, again, I would like to thank you for having us here so that we can demystify those myths that have been peddled out there. It might be a cultural issue because generally for us, we never used to practice these things. And due to cultural barriers and stuff, maybe cesarean section at times might be viewed as failure of pregnancy. But back to my starting point, as I said, at the end of the day, you do not want to go through that whole pregnancy journey, carrying your baby in the womb for all those 9 months and then go home without a baby. Or also you fail to go home because of something that would have been prevented. So at the end of the day, if at the back of your mind you have that, at the end of the day, I will go home as a healthy mother with a healthy baby, with my supportive partner. That's all we want. And that in itself is a win.
Wow.
Yes.
Profound. Maybe, Doc, you can tell us, once a mother arrives at the hospital,
Yeah.
when you're assessing labor,
Yeah.
then what are some of the warning signs for surgery, for cesarean? Then when is an emergency cesarean possible or taken as a measure? And how does a planned cesarean section as well happen?
Okay. Generally, first of all, the first encounter that mothers will have with doctors or healthcare workers, depending on the level of facility that you've attended, the first contact will be through the ANC clinics. Through the ANC clinics, a lot of things are measured. Your blood pressures are measured. The lie of the baby, because we favor, sometimes there might be breech presentation, and other parameters that are measured during your random blood sugars, Your HB will be taken. Your screening for venereal diseases, screening for HIV, hepatitis, all those things will be measured. And during that time is when risk is assessed. Yeah. So there are some pregnancies that are labeled as high risk, others are labeled as low risk. Yeah. So for the high risk pregnancies, most of them, the safest mode of delivery will be cesarean section. While those that are considered low risk, the safest mode of delivery will be considered the normal vaginal delivery. So there are some indicators of absolute indicators of cesarean section, and others are not. But just to go in an overview of everything, so we have two types of cesarean sections. We have an elective cesarean section and we have an emergency cesarean section. I will start with the emergency cesarean section because it's the most common cesarean sections that are done. Although electives, due to the fact that once you undergo a cesarean section, sometimes the subsequent deliveries might have to be done through cesarean section. It does not mean that it's always the point. You might have had a saying that goes that once a cesarean section, always a cesarean section. But that's not always the case. It's just that in our Kenyan settings, we might not have the monitoring capacity and technological advancements to deliver safely. That's why in our setting, most of the time, the safest mode of delivery after a previous cesarean section will be a cesarean section. Okay. Yes. I get that. So for the elective cesarean section, this is when you and your doctor sit down and plan on a day where the cesarean section or the delivery will be done. And this always happens before labor progresses. So the mother has not gone into labor when this cesarean section is planned. So there might be risk factors. We might have twin pregnancy. We might have breech presentation. Another indicator of that will be that during our assessment, we've noticed something called cephalopelvic disproportion. That is when the baby of the head of the baby cannot pass through the vaginal canal, and that could be due to the pelvis, the shape of the pelvis of the mother. There is an ideal pelvis for delivery, and after our measurements, we find that the baby cannot pass through there. We will have to, we plan for a cesarean section. There are also others which have something to do with maybe the placenta, how it's attached. The placenta might block the opening of the cervix, and that will mean that you cannot really deliver through a blocked cervix. So there are also other diseases, especially gestational diabetes and preeclampsia, which might necessitate us to do a cesarean section, a planned cesarean section. For the emergency cesarean sections, most of the time it's when the progress of the labor is not ideal or poor or inadequate. Let's say, for example, generally labor has different durations depending on your parity. Parity is the number of babies that you've had. So the higher the number of babies that you've had, the more likely that the shorter the duration of labor. So that will lead to prolonged labor. If prolonged labor is there, it will lead to fetal distress, and we do not want ile yenye tunasema mtoto amechoka. So tukipata hiyo, that's when we do a cesarean, an emergency cesarean section. Also, there could be other factors. Let's say there could be a lot of bleeding. That is antepartum hemorrhage due to any other reason. And that is when we see that the risk of delivering the baby normally, vaginally, is higher. That's when we do an emergency cesarean section to save both the lives of the mother and the lives of the baby.
Profound.
Yes.
So it's a process that you have to think through completely.
Yes, sure.
And maybe that's why we have brought this team here.
Yeah.
Somebody thinks when they think about us here, they only think about the doctor.
Yeah, it's a multidisciplinary.
So you can just talk about the role you play in that particular team.
Yeah.
So let's begin with Shem here.
Thank you very much. So my role as an anesthetist, when the doctor screens you through the NC clinic or in the ward, they make a list that is brought into the theater. And when the list is brought into the theater, I'll assess if it's an elective or it's an emergency. Either way, I'll have to come personally and review the patient. And during the review of the patient, I will want to see the presenting issues, how long they are with. Maybe the patient is having bleeding, how much the bleeding is, and the measures that have been taken. I'll also want to see, I'll ask about the past medical history, past surgical history, and if there have been any previous history of surgery. Have there been any events during the anesthesia in theater? I'll want to know that. And in past medical history, I'll want to know if there's diabetes, the patient is asthmatic, the patient is hypertensive, because they'll affect the mode of anesthesia that I'll give intraoperatively. And after that, now I'll go to I'll look at the vitals. Remember, they were taken somewhere. So I'll want to see the vitals. And during the review of the vitals, I'll also see the NC profile and screen if there was anything major that was captured. So in the vitals, if the vitals, that is the blood pressure, I want to see the saturation, I want to see the heart rate of the mother. At this point, I'm more interested in the mother, because the doctor is not more of the mother, but both the good outcome of both mother and the baby. So I'll check at the heart rate of the baby and the fetal heart rate now. I'll also check at that. And if there was bleeding, I'll want to see how many pads the mother has used. If it's fetal distress, I would want to see how, for prolonged labor, I would want to know how many hours the mother has been in labor. Yes, and the cause of the distress, I want to know. Then systematically, I will examine the airway and to make sure that in case I want to do an intubation to this patient intraoperatively, I'll be able to do, and I'll classify that. There's a way we usually call it Malambati classification. Then after the neck movement, if she has the wigs, at some point they will affect how I will do my intubation. Then after the airway, I'll go down systematically to the chest, the heart, and the other systems also. I'll assess them. And then after that, now I'll check out the investigations that the carrier has ordered. That is fullemogram. I'll want to see the white blood cells. I'll want to see the HB and the platelets, because they will affect in theater. If you have a low HB, we might need to transfuse you intraoperatively. Platelets, they will affect the bleeding. So if they are low, we might need to have platelets in standby so that we can transfuse you.
Wow. I think.
And after now, now I also want to see the UCs, I want to see the obstetric ultrasound, and then now I'll classify the risk factor of this mother, and that is ASA classification. Then from there, now I'll make my own recommendations. I will make recommendation. One, we will have to sign consent for the procedure. So that during the signing of the procedure, that is where we will discuss the mode of anesthesia that we have for you. That is the mode of anesthesia. There is the spinal anesthesia we will give, or the general anesthesia. So spinal anesthesia is where we block at the subarachnoid space, and the paralysis goes down, but it wears off afterwards. And general anesthesia is where we give you medications through a vein, intravenously. You lose your consciousness during the procedure, and when the procedure is over, we reverse it back. Wow. So we will discuss about that, and for the safety of that is for the safety of the baby and the mother also. And from there, we will also want to know the last meal the patient had, and also keep them in power and make sure they don't eat anything. And from there, you'll be good to go to theater.
Wow, maybe you can, there's a fear around the spinal anesthesia. maybe address the myth that there are tendencies of maybe developing paralysis, the pain, back pain. Over some time, you begin to develop unnecessary back pains, and the safety of it. Is it painful? Is the mother able to interact with the baby during that particular moment? Maybe just fix that in a minute.
Yeah, thank you. So in spinal anesthesia, generally we just block at the subarachnoid space from lower down, and during the surgery, as the incision is being made for the extraction of the baby, usually you can feel whatever is happening, but you can't feel pain.
Oh,
yes, you can't.
So you're
pain.
alert.
Yes,
You can see the entire process.
Yes,
but there's no pain at all.
Yes,
Okay.
and the paralysis, it wears off
Over some time.
Yes, yes. The drug has a duration that takes time. That's around 2 to 3 hours. So by the time 2 to 3 hours, it wears off and you are able to walk and you are able to ambulate within the hospital, set up and for easy recovery.
Wow.
About back pain, most of the time, patients tend to associate it with the spinal anesthesia. However, it's more of the muscle spasms or the physiological changes that happen during pregnancy that mostly bring about the back pain.
Back pain.
Yes,
It is
because
not
during
related to the anesthesia.
because before we give the spinal anesthesia, we give local anesthesia at the site of that you are going to administer the drug, and there is a technique that we usually give. The technique that we give is it's more separated. It's more of separation of the muscles than cutting them.
Oh,
yes. And when we deposit the drug, we come out and it's
Wow.
just a small incision.
profound.
So
So
people should not be afraid.
they should not be afraid.
Yes.
You do a local anesthesia, meaning they won't feel the pain of the spinal anesthesia.
Yes.
Then after that, it wears off over time. Then
yes,
you go back to normal. The back pains are not related to the anesthesia. It's the journey you've gone through as a mother.
Yes.
So it's a foreign object in your body. It has some effect on the physiology and the structure.
Yeah, the center of gravity changes.
Changes. So when you begin to come back to who you were initially, that change has an effect on your. So I think that is very clear to them. Maybe now we've said that cesarean section is a team effort.
Yes.
Now we come to you, Bwana Mudavadi.
Thank
What
you,
role
sir.
do you play?
Okay, thank you, Sano. Now, as my colleagues have discussed, during theater process, a mother who comes to theater, it's an interactive session, and one of the things that most mothers have usually it's anxiety. You see, now even before the mother comes to theater, the allaying of anxiety starts way right from clerking the patient to the theater. So my role basically is to ensure that this mother has transited well throughout the journey of cesarean section and back to the ward. And even after the surgery, back to the ward, the patient has to ensure, like we've given enough health education on how she will behave thereafter until she recovers fully. Now, basically my role when the patient comes in theater, we do what we call a checklist. If this patient certainly suitable for this surgery. If we note that this patient is not suitable for the surgery, it's a multidisciplinary thing. We shall discuss with the doctor, with the anesthetist for alternatives. See? Now, the first thing, you have to ensure that this mother, the biodata of that patient is fully noted. You see? The essence of this is to ensure that you've done a correct surgery to the correct patient. You know, we have instances of whether you've done a different case to a different patient. It's usually something that we avoid by doing so. So biodata of this patient you have to note. And also it's good to ask the mother, what's your full name? She verbally indicate that my name is so and so. So from there you see that you ask even her, why have you come for cesarean section? It's also good it's an interactive session. It's also good to know that you've been told my situation is 1, 2, 3, the way doctors explained. That's why I'm here.
Yeah.
See, we have to ask several questions like, do you have any allergies? Because such things, you can easily forget them, but it can affect the outcome of the procedure. You see, apart from also the allergies, we have to check the blood works. We have to know that all the parameters are okay. And if not, for example, we've noted the patient has low HB. What should we do? We should have to engage the laboratory team And the anesthetist will also be aware that this patient has low HB so that we source for blood. See? So all this is to ensure that that patient has transited well to the journey of cesarean section. Now that is on a receiving area. We check the biodata, the allergies, if has sun consent, and also the medication. We usually encourage antibiotic to be loaded 1 hour, usually at least 1 hour before the surgery. And I will tell you why on the subsequent talk. Now, from the receiving area, this patient has gowned, all the metallics have been removed, all the other foreign cloth has been removed, usually remain with the gown alone. It's just a matter of infection prevention control measures. Even us, when we enter into theater, we have to remove all our clothes that will come there from home to wear other scrubs like these ones, you see? And we all have to close our hairs and also our mouth. Now, from there, we transit this mother to an operating room. On the operation room, we also do what we call signing progress. So signing, we triple check with the help of the surgeon, the anesthetist, the scrub nurse, and the circulating nurse. We counter check. Are you Shem? You see? Again, to ensure that this is the correct patient undergoing this surgery. Again, do you have any allergies? Did you sign consent? Are you the one who signed it or your spouse? You see, we cannot do a surgery that you have not consented.
Yes, sir.
You see, then if all other parameters are okay, the anesthetist have ensured that the anesthesia will be safe. We now give the anesthesia, and the patient lies. Now, during that patient, we have different people in theater. The surgeon, the anesthetist, we have a scrub nurse, and we have a circulating nurse. I will tell you the role of all these nursing positions. Now, the scrub nurse will ensure that the theater setup is well equipped with all the instruments that we need for cesarean section. Not only that the instruments are available, but they are sterile. When we say that something is sterile, all the microbes that can cause infection to the mother, it has been killed by a steam or chemical sterilization. You see? If we doubt that something is not sterile, it's better we don't do that case.
Yeah.
You see? So, and again, to prevent that infection, we talked about the antibiotic. Yes, we also play a part on it. Now, when the mother is on the table, we do this circulating nurse. Circulating nurse is a nurse in theater, operating theater, who ensure that all the equipment and supplies that you need are available at you. You see, and also takes the vitals of the patient intraoperatively. You see, if there is any hinge, discuss with the anesthetist and control it. Okay, and also you do what we call antisocial social wash. We wash the incision site with an antiseptic, either chlorine scrub, or if at all you don't have all those, you have the normal soap and the gauzes. You scrub where you have to make an incision. All this is to reduce the level of bacteria that are on the skin. You see? Again, during the surgery, after you've draped and you've done the scrubbing, you've done proper hand washing, and you've gone to prepare the things that you use or items that you use for surgery. Now that's a role of a scrub nurse. You see? Again, during scrub nurse, we have to ask during timeout. We do timeout. Timeout is as WHO is a standard checklist, which before the surgery starts, we call everybody to attention. We go through the timeout.
Amazing, Doc. I see our time is running really nicely. We can begin from that timeout.
Okay.
Then proceed what happens after there. Then we launch into recovery. So a patient has gone through the procedure. What does it look like in the recovery room? And as we are running into a short break, it is a time for you, our viewer, to send in your questions, to send in your comments. Are you learning something? Is it becoming clear for you? And this is proudly sponsored by JCK Hospital. This team is the team that you're going to meet at JCK Hospital. And whatever they're saying here is what they're doing. So man, it's more about safety, it's more about quality, it's more about compassion. So as we run into a short break, I recommend that you share in your questions, share the assumptions you had that before, and everything that you'd like to ask our doctors here, they're going to be answering. So before then, I'll see you shortly.
Every great journey begins with a single step. And at Jesse K. Hospital College of Health Sciences, that step is met with warmth, guidance, and possibility. Here, learning goes beyond the books. It is where future healthcare heroes are nurtured by passionate instructors who believe in their potential. From theory to practice, our healthcare assistant students gain real-world skills in real healthcare settings, preparing them to serve, support, and make a difference from day one. Because at Jesse K. Hospital College of Health Sciences, we don't just teach healthcare, we empower excellence. Admissions are now open for our January and February intakes. Step into your future today. Find us at Blessed House, 5th floor, opposite Garden City Mall. Jesse K. Hospital College of Health Sciences, empowering.
Just left in the first segment, then we shall look at how does it look like after recovery. When we talk about you finish your procedure now, you're recovering and even going home, what does it or should it look like in the ideal situation? Most of the times, there are people who their families are not supportive, they do not know what to do. But today, you're going to make sure that you get to learn that within the shortest time possible we have. Thank you so much for the support you've shown over the time. And even as you share your questions, you're going to find some time to answer them. So thank you for tuning in once again. Maybe, Doc, we left it at timing out.
Time out, yes.
Yes. Pick it up from there.
Thank you. Welcome back again. Now, we talked about the timeout. Timeout is a WHO checklist whereby we go through it one by one, and it's a session. So we usually start by asking the surgeon to introduce herself and the team. You see, so it is important for everyone who is there to know who is this and the role that they are taking. Okay, and of course, before the surgeon and the anesthetist and the whole team introduces themselves, the scrub nurse and the assistant, together with the circulating nurse, the role of this timeout, the circulating nurse is the one who is taking this team through it. So the anesthetist, the surgeon, and the scrub nurse, they are listening and complying to what the circulating nurse is saying. Now, the circulating nurse will go through the timeout, will say, this is patient so and so, and we have to also to confirm. We can ask somebody to confirm through the name tag, the same biodata, the 3 names, the IP number, the inpatient number. That's a unique number that is given to each and every patient. You know, nowadays names are zinafanana.
Yes.
Unapata mtu anaitwa Mary Wanjiko. So you have to say the 3 names together with the IP number. Now, from there, we go to the surgeon, introduce themselves that this patient, he has come up due to this. You will find we repeatedly say some things It's not that we like repetition. Just to emphasize that this mother has come for cesarean delivery due to breech presentation. You'll find the doctor describe it back to the ward to the patient. On receiving area, we also ask the mother, and also the anesthetist asks the mother why you've come. And also in the operating table, you have to ask again to say that this is because of this. See? So it is a series of continuous repetition of some things to emphasize on the things that you are saying. Then other duties, we'll ask the anesthetist if everything is okay on his part. We will mention the surgeon the same, the scrub nurse the same. The scrub nurse will count the gauzes, the number of gauzes, the number of sharps, the number of sutures that you are using. Sutures are the ropes that we usually use to shorten the uterus. We do it before. We count them before the surgery. Then after the surgery, before we close the abdomen, we also have to count the number of gauzes that we used, the number of sutures, the number of blades that we use. To ensure that there is nothing. You know, kuna kuwaga na ile rumors, tulisahau kitu kwa tumbo ya mama. It rarely happens. So this time out, or rather the checklist, it's suitable to ensure that hizi vitu hatusahau ndani. You see? Now from there, after we've closed the patient, we'll carry this patient in a good position to the recovery room. The recovery room, we have a PACU nurse. PACU nurse is a post-anesthesia care unit nurse designated to take care of this patient or monitor this patient until the patient is fully awake to go back to the ward. You see? Now, at that point, we monitor if there is any vaginal bleeding. We control pain. We look at the parameters of the vitals. You see? You know, it's not that that's the matter of looking of the vitals. You know, different vitals communicate what's happening to the patient. You see? Yes. Now from there, we have ensured that the patient is safe, free from pain, and fully awake. We have different documentation that we do. You know, in nursing, we usually say, if you've not documented anything, you've not done. You see? I also hope the same thing applies to
it applies.
Yes. If the doc say that the anesthetist say that I gave bupivacaine as the anesthesia, and you've not documented it,
It was not done.
Not done. So again, we document everything. Then from there, we also notify the ward nurse to come and pick the patient. Even though the ward nurse is the one who brought the patient, he knows the condition of the patient. When he comes back to pick the patient, he has to assume that I don't know this patient.
Again,
you have to
go back and verify.
Yes, this patient came because of 1, 2, 3. We've done 1, 2, 3. This is what we've given, and this is the pain medication that we gave. The nurse will check if there is any vaginal bleeding, because you cannot hand over any patient if he has any vaginal bleeding, or if the patient is not fully awake. You see? Again, you describe all that until the patient goes back to the ward. Apart from that, I know I'm running out of time, but apart from that, it's also my duty as a theatre nurse to go back and educate that patient back to the ward. When she goes home, the safety measure that she has to take. You see, we have, like, for example, leave alone the exclusive breastfeeding that you should know and all those stuff. We have other issues because these mothers are undergone cesarean section. We have to educate about lifting heavy things. You have not to lift heavy things. Things like heavy work. Okay, we are not saying that you don't do work, but slight exercise that will prompt you to do some 1, 2, 3, but not heavy. You see, because it is a probability of rupturing the incision site is very high. Again, even the coughing technique, how you're supposed to shower, wound care, you see, all those we discuss with you before you go home. Again, this mother will have some vaginal discharge. We also describe to the mother that you will have a vaginal discharge. It will change colors from this to this to this, so that usikue nyumbani ukashanga hizi naye kunaenda aje. You see? So we have those health education series that we should give to the mothers, so that akienda home anakuwa.
Maybe something I'm discovering about this, it's quite a robust system, and safety is very important. From the names they put in the detail, in the documents, the procedures done, and the reputation is to make sure that the safety safety has been taken care of. So maybe now I want to shift gears a little bit. Doc, now the patient has just finished. Now, before he even goes to the recovery room,
Yes.
he has just finished. He has just gone through the procedure. But I would like you to demystify it. Why is it early mobilization that the movements after surgery? Why are they important?
Okay. Maybe I think we've gone much ahead. We've jumped the broom, but generally my role as a doctor or as a medical officer in that place will be to diagnose the patient first. Then after that, perform the surgery and then subsequently follow up the patient in the ward. So I think they've gone through much of the admission process, diagnosis. We've touched a little bit into that. But let me go now through when performing the surgery. Now, after timeout has been confirmed, the surgeon is usually the team leader. So in as much as you're performing the surgery, you have to be aware of your surroundings. You have to know what's happening around you. Because there might be breaches of sterility and
Now the guy wants to perform a surgery before given anesthesia.
Come and tell us any complications that developed from that anesthesia.
So after Shem has given anesthesia,
Yes.
so after the anesthetist has anesthetized the patient, also they assess the risks there. So sometimes we might have even to switch from one mode of anesthesia to another, intra-op, depending on the case. I think we had such a case recently where we had to, because the surgery was quite prolonged and had some comorbidities and complications that we had to deal with during the surgery. So generally, after the social wash has been done, we scrub and gown, anesthesia has been given, we make an incision in the lower abdomen, whereby after that we separate the muscles, not by cutting, but as Mudavadi has said, but just by stretching them apart, and then we are able to access the uterus. The uterus is the womb where the baby is. Then from there, we just cut the uterus from down there and then extract the baby. After extracting the baby is also handed over to another nurse who will take care of the baby. If resuscitation is needed, resuscitation will be done. For us, we continue with the procedure. But we also show the mother of the baby after extraction, because you want to know the gender of your baby, so that we stop these cases whereby you say, oh, my baby was exchanged. I gave birth, my scan said that it was a baby boy, now it's a baby girl.
And also if there is any congenital anomalies.
Yeah, any congenital anomalies. We've actually dealt with one which was quite severe, and we had, you have to, even if it's distressing to the mother, it's better done than not done. So after extraction of the baby, the placenta is delivered. After the placenta is delivered, we start suturing repairing the uterus again. After that, that's when again another theater checklist is done, where the sharps are counted, the gauzes are counted, everything is, after we confirm that everything is in order, the anesthetist has confirmed that hemostasis is achieved, hemostasis, that there is no bleeding, everything is in balance. That's when now we close up the abdomen in layers, the same layers that we went through going in, we'll close them up in the same way that coming out. After that, we suture the skin. We perform some maneuvers maybe to get rid of the blood that maybe had collected pervaginally. That we call it vulvovaginal toilet. We also administer some medications, at least to help uterotonics to contract the uterus. After that, the patient is dressed, operation ends, and then that's when the patient is taken to PACU now for recovery and monitoring.
Wow.
Then after that, we'll now meet in the ward
for follow-up. Great.
Yes.
I want us to take a few questions, then we'll listen to Bwana Kyalo here.
Yeah.
I know she has some points to give us. There are people asking, and I'm glad that people are watching from Lumumba Drive.
Yeah.
Hello, I am Anne in Lumumba Drive. Can stress during labor increase the chances of ending up in theater?
Okay, yes, yes and no. Yes, in this way. Also, the cooperation of the patient during the labor process is also an important factor when it comes to the outcome of the delivery, whether by cesarean section or by, let's say, if you're stressed up, also your physiological parameters might go up. Let's say your blood pressure might go up. Maybe Shem might tell us more about how blood pressure affects maybe during cesarean section, its effect during there. But from my experience, what I will say that if the mother is stressed, also the baby is stressed, and we might end up always in cesarean
section.
Yeah.
Wow. You have something to add on that?
About stress.
Yes.
Generally, if you're stressed, you might end up in theater. So it's
Theatre.
good. That's in pregnancy. It's usually you should have to plan yourself as a mother, and that is why the NC clinic is there to enlighten you and your partner about the process and prepare yourself so that you don't get stressed and stressed. When you get stressed, it automatically transitions to the baby.
Wow. Maybe someday we shall create some time and get to talk about the NC clinic and why it is important. The people who've they've gone for a checkup maybe the day of delivery, and it's very dangerous. Rose is asking, my first baby was born through CS. Does that automatically mean all my future babies must also be born through CS? Once a CS?
Always a yes. It's a myth. Maybe Mudavadi will answer that.
Okay, it is something that most mother believe so. But again, to answer that question, it depends with what made you went for CS. Yeah. So we have maternal factor and we have the baby factor. You see, so like we have a condition like the pelvis that Daktari talked about. If the pelvis is not adequate for normal delivery, that will prompt you to have cesarean section for the rest of the babies that you have. But if you have a condition like, let's say, meconium is mtoto amechoka, ile mnasemanga mtoto amechoka, alafu amepupu. So unaona anatoa maji ikipasuka inakuwa kama greenish. So that one, it is not like, it's a maternal, it's a baby factor. So we can have something we call trial of scab. Okay. But of course, all this is coordinated and ensure that you go, if it is normal delivery, you perform it very well. If not, but you might end up.
And there is also a certain criteria that you have to fit in for you to try labor after delivery. I think it's called VBAC or TOLAC, both of them.
Yeah, today it's a bit technical, but I hope to try labor. Okay, another one. I keep hearing women say that they felt pulling and pressure, but no pain. What does that actually feel like? Sounds scary still. Helen. Sorry, Helen. I'm sure after this you no longer be scared. Maybe who has some comments on that?
I think Shem is the mganga there.
So when the patient comes in theater, we will reposition you, give local anesthesia, then give spinal anesthesia. Then we will reposition you on the operating table. And from there, we will give you the danger signs that when the spinal anesthesia mostly comes with the hypotension, low blood pressure. And there are things that might elicit while there on the operating table. That is, you might start feeling nausea, you might start vomiting out of nowhere, dizziness, or breathe. You can't breathe well. Most of them, unasikia anasema daktari sipumui vizuri. So that means your blood pressure is low. And there are drugs that we give to counteract, and there are maneuvers that we can tilt the bed to the left and all that to make sure that blood pressure is okay. So, and that's the low blood pressure is somehow a good sign to us because it shows you that the spinal anesthesia has picked up. And the spinal anesthesia, remember you're giving it at the subarachnoid space, and it blocks the nerves that are coming from that area. So when all the nerves that the innervation in this area that are blocked, you tend to have muscle relaxation, and also the sensation goes and the motor goes. So sensory has gone, motor's gone,
Yes.
and the autonomous
Nervous system. Yeah.
yes takes over. So there's no pain and there's no motor, so there is paralysis. So you'll only be feeling some pull and push. Yes, and unless there's some maybe a pressure, there's fan of pressure that is applied, you might feel some discomfort or pain. But down at the level of the block, you don't feel anything.
Wow.
Just pulling.
Yeah, the pulling is when you are
it is very
separating all the
normal.
muscles.
It is expected. It is normal.
Maybe a quick one.
Yeah.
This is Gloria in CBD. Thank you so much for watching us, Gloria. It's good to have you. Is the scar on the uterus as strong as it was before surgery? I think that's a quick one.
Okay, the scar on the uterus, I'm assuming that this is a person who's undergone cesarean section
Yes.
during the first time, and they are having another cesarean section, because the uterus normally will not have a scar if you're not given birth by cesarean section. So what I will say is that the subsequent scars tend to be weaker, because for the abdomen or the skin, we go through the previous scar, so you get a fresh scar. But when it comes to the uterus, we usually try as much as possible to make the incision where the previous scar on the first scar was made. Sometimes it might not be possible, so you might have multiple scars, but generally that's why we discourage, maybe in normal delivery we might not give you an absolute limit of the number of babies that uterus can carry, but during cesarean section, I think it's recommended 3 to 4 maximum, because because we do not know, you might actually go into labor before even if it was an elective cesarean section, and that scar might rupture. So subsequent pregnancies, the scar becomes weaker and weaker and weaker.
Maybe as we conclude, 2 questions. I just remembered something on once a CS, always a CS. For me, my mother delivered me through CS, but my sisters, all of them, have been delivered on normal delivery. So it's not a guarantee that you're going to go through that process your entire life. Somebody's asking here, maybe a good question, Timothy. How can men best support mothers during recovery?
How can men?
Maybe each can give just 1 point. You're men here, so give me 1 point. 1 point. 1 point. Yes.
Generally, just be there for your partner.
Be there physically,
emotionally, yes. And in case they need anything,
make provisions.
Yeah,
Okay, that's a very good question, and I like it. The person who asked that is a very crucial thing, and it's very good. Okay, for men, it's not only after delivery, before even conception.
Yes.
Before even conception,
Japan.
lazima ukwe there for the mother. We usually say for a good labor process, the mother should be good in social, you see, mentally, and physical. Physical, social, and
Mentally.
physical in terms of the activity that he is doing, and unajua kuna ndoa zinakuwaga na physical fight and all those stuff can affect the mother. In terms of emotion, the mental part, kuna wale wana deliver na develop puerperal psychosis, is a disease we shall discuss another later. So a bad partner, or rather tuseme mwanaume anaweza changia a mother kukuwa na puerperal psychosis. You see? And the social one, in terms of the home setup, na pia penye na interaction na watu, is another factor. So man comes up in a way that after delivery, let me just answer what he has asked. After delivery, physically, you have to support the mother to carry the baby at some point, and also difficult task in the house. And emotionally also, you have to be there in terms of akona issue. Najua whether normal or cesarean section, mtu anatoka huko anakuwa na issues like anasikia different na hizi communicate. You know your partner better. Nampeleka house in a good way. So it is a collaborative thing. I encourage the male partner to support their mothers even before conception.
Wow, thank you. Maybe as we conclude, Shem, just tell us, what is one myth about anesthesia which people should stop completely believing?
One is kindly stop fearing anesthesia. It's a good thing. It takes away pain and it makes sure you are comfortable in theater during the procedure. Yeah. Then the staffs are usually well trained, and the drugs that we give are well titrated for your surgery and according to your need. So don't be afraid of anesthesia.
So remove the mistrust.
Yes.
I want you to complete this sentence, even as we come to a close. I'll begin with you, Doc.
Yes.
Safe motherhood begins with?
Attending your ANC clinics.
Safe motherhood begins with attending your ANC clinic. Yes. Dr. Mudavadi. Safe motherhood begins with?
Safe motherhood begins with a good mental state, good social cycle, and good physical state.
So a good mental state or a psychosocial state and a good physical state. So you have to take care of it.
Yes.
Shem.
And tickle.
And maybe Stanley.
Yes.
Maybe as we wind it up. One thing that people usually fear, not only cesarean section, when they hear something theater, they feel like it's a bad place.
What do we call it? The white coat something.
White coat hypertension.
Automatically.
Yeah, the blood pressure goes up.
Kindly, let's educate our members in the public section that theater, when you go to theater, it's not a bad place. It's a corrective
It's not a death
place.
sentence.
Yes, it's not a death sentence. It's a corrective place.
Yes.
You see, for example, if you've got a fracture and you have been scheduled for theater, we are going to correct that fracture, my friend.
Yes.
It's not that we are going to kill you.
You have to walk again.
So let's think that it is the correct place.
Wow. I love that. I love that. That theaters, God put them as his place of function. Yes. That is where he's working with the doctors to correct the mistakes, because he cannot come here physically to correct a fracture. He cannot come here physically to correct a wound that you just injured yourself.
Because, for example, if let's say maybe you have inadequate pelvis to deliver normal way. So does that mean that you will die with your baby?
No. And there are mechanisms.
That's why the theaters are there.
So a theater is not a bad place.
Yes.
It is not a death sentence.
And again,
it is not mortuary.
Again, most of the mother, especially in private hospitals like ours, kuna wengine wanakuaga na ile diversification, like ukienda huko, you will definitely go to theater. You know, definitely go to theater. My friend, it's not our wish that all of you pass through theater.
Yeah.
The doctors, the way the doctor has said, the way the anesthetist has said, we have to screen you for you to be legible.
For the theater. It's in fact not your best choice.
Yeah, it's not the first choice. We will do everything in our power to prevent you from going to theater. Yeah. And we only do it when it's inevitable.
In the event you land there,
you
are in safe.
You're in safe hands.
Yeah, and maybe I know you want to conclude.
I want us to finish up.
Yes. But in JCK Hospital, we do a wholesome and a very lovely session.
Yes.
If you come there, believe me, you will enjoy the session. And it's not only these medical jargons and terminology that we hear. We talk to you, even if you are a Kikuyu, we find you a Kikuyu guy that you will understand why. You see? And it's a very nice place, very interactive people.
Yes.
Hata ukitaka music yenye unaitaka, you will listen to it.
And even so, you have private wards.
Of course.
You have a proper proper furnished theater.
And the music you are saying in theater, as your baby is coming out, you are listening to your favorite music.
Serenading in theater.
Yes.
Oh, wow, I love that. Maybe now
it's a way of anesthesia pure.
Mental anesthesia. I love that. So lastly, as we come to a close, in 15 seconds, parting shot, 15 seconds. So be as short as a miniskirt, but long enough to cover the social. Okay, clear that up. 15 seconds. We are done.
Yes, thank you for having us today. I think we've demystified the myths that were going around concerning cesarean section. And if you're a mother who's had a previous cesarean section or would like to deliver at our hospital, you can feel free to pass by, check out our facility, check out our theater, and we'll be ready to receive you at JCK.
Karibu sana.
Yeah.
Daktari, 15 seconds.
Yeah, thank you so much. Once again, my name is Mudavadi Vincent. I'm a theater nurse there at JCK Hospital. Karibu JCK.
Yeah.
Shem, asante sana. As an anesthetist, I'm an advocate for safe anesthesia.
Wow.
So you're welcome.
Yeah.
Thank you.
It was an amazing team. It was an amazing time, and I'm sure you've helped very many people out there. It is still a reminder, JCK is your preferred medical provider for this season. They have very many insurances. They accept SHA, they accept it for civil servants, they accept it for other citizens. So you could just hop in. Where are they? For example, Lumumba Drive, next to Park University.
Yeah,
if you are in Juja Farm, find them at Kambe, next to Happy Life Christian School. If you are in Moranga, do you know Mariaine? Go to Mariaine, ask for JCK Hospital. We are serving you with love. Health for the mind, health for the body, and health for the spirit. Until next time, to this end, adios, muchachos. Peace.
At JCK Hospital, we understand that a child's smile is priceless. That's why our dental services are tailored with care and compassion to ensure your little ones have the best experience possible. From gentle checkups to specialized treatments, our pediatric dental experts create a safe and friendly environment, making every visit fun and stress-free. Because we believe healthy habits start young. And for the grown-ups, we've got you covered too, with top-notch dental care for the whole family. Visit JCK Hospital today, located in Roysambu, opposite Park University on Lumumba Drive, and experience dental care that's gentle, professional, and family-friendly. JCK Hospital, you first.
Sasa nakuwa pana kazi ngumu kwa. Nadhani usina itaanza kuwa fit. Umeflow man. Umeflow. Teka nyuma kidogo pia. Inafaa. Sio hiyo position. Sasa sijui kama tuambie baadaye kwa photo, nataka tupige picha moja hapo karibu. Wanaocha kufikiria pale. Tunaelekea hivi sijui.